Thank you for taking the time to watch this video. A pre-video disclaimer. Some of these tests were only demonstrated on one leg for the time purposes. It is important to note that all tests should be first performed on the leg not producing the comparable sign, the uninvolved leg, and then on the involved leg, the one that is experiencing the symptoms. Alright, let's begin. One of the best tests to determine if there's neurological involvement with the patient is the slump test. It causes tension along the dura from both our head and feet ends. Have the patient seated. Instruct the patient that you will be putting them into different positions, and if any of the motions or positions recreate their complaints or produce any symptoms in their legs, to let you know. Ask the patient to put hands behind their back and to go into a significant slouch. Instruct the patient to bed their head down, chin to chest. Hold the patient's head still, do not push on their head. Test one leg at a time, starting with the uninvolved leg, if there is one, then the involved. Ask the patient to bring one leg out, that you can passively help them extend it. If at this point symptoms are produced, you can stop the test here and have the patient look up towards the ceiling. If they do not feel any tension in this position, you can increase stretch to the dura by applying dorsiflexion to the foot. If at this point the patient says yes, this is creating the symptoms in my leg, then have the patient look up towards the ceiling and ask did that create any change in their symptoms. If the patient says yes, that feels much better, that's because you have let the stress off the dura. This will be a positive slump test. If lifting the head up creates no change, then it's probably just hamstring tightness. This will be a negative slump test. Next, we will demonstrate the sympathetic slump test. It's similar to a classic slump test, but you will want to perform this test if when you are examining a patient's thoracic spine, they are having complaints that are sounding autonomic, things like sweating, symptoms sounding like sympathetic nervous system is getting involved. You can bias the slump test to target more of the thoracic spine, due to the sympathetic chain running along here. By going into the position, you are going to be creating more of a stretch to this area. Have the patient begin in long sit. Place their hands behind the back and slouch down again. Ensure the pelvis is slouched down as well. In the case of the sympathetic slump test, we are trying to stress a specific side. So if trying to test the left side, the examiner will step on the patient's right side and the patient will have their left knee bent and the right leg extended out straight. You will then side bend and rotate the patient into yourself, kind of tucking the patient in towards your body. Ask the patient to bring their head down and again hold the patient's head still and ask them to slowly extend and straighten out their left leg to let you know when they feel their symptoms recreated. At whatever point of extending their leg out, the patient notes their symptoms get reproduced, ask the patient to stop and look up to see if that changes anything. If it does, this will be a positive sympathetic slump test. If not, that is a negative sympathetic slump test. The straight leg raise test is another neurological test that can be performed to check the dura of the lumbar spine. Have the patient lie supine. Ask the patient as you bring their leg, the uninvolved, then involved, up to let you know at what point their complaints are being recreated. Then begin by passively lifting the patient's leg up until the patient states, "There are my symptoms," or "There is my pain." Advise the patient to now tell you when the pain or comparable sign goes away as you slowly bring the leg back down until the patient states their symptoms have stopped. At that level, you will then try to resensitize the pain by passively dorsiflexing the patient's foot. If the patient states the symptoms have been recreated again, then we'll ask the patient to lift their head up, chin to chest. Ask the patient what has this done to their symptoms now. If the patient states worse, this is because you have now increased the stretch in the dura. This will be a positive test. If the patient states she feels better when lifting her head up, this will be a negative sign and can mean the hamstrings are tight and that is the stress the person is feeling. How to now grade the straight leg raise test. If you perform the test on the left side, and the left side is where symptoms are reproduced, that is the standard straight leg raise test. If the patient the pain feels is primarily in the back, it is more likely a disc herniation from pressure on the anterior theca of the spinal cord. If the pain is primarily in the leg, that is more likely to be that the disc pathology is causing the pressure is more lateral. A factor to note when assessing the straight leg raise test. If the patient reports of pain before the legs have been elevated to 35 degrees, this would be difficult to interpret because you need to create at least 35 degrees of hip flexion to create some movement of the dura and create tension to the sciatic nerve roots. Between 35 to 70 degrees, the sciatic nerve roots have tension over the intervertebral discs. This is the range we're looking for to create the positive response for dural tension. After 70 degrees, no further tension is being placed on the dura or sciatic roots, and if the patient complains of pain in this range, most likely it is a hip joint issue. Keep in mind people who are hyperimobile. The ranges for them might be a little different. This is why it's important to do the uninvolved side first, then the involved. If performing the test on the left side and the patient complains of symptoms on the right side when bringing the leg up, and then when the patient lifts chin to chest, this also makes it worse on the right side, this is a positive cross straight leg raise test. Prognosis for these is a bit worse because it's more likely associated with a large central disc protrusion or a space-occupying lesion. Another neurological test you can do is a femoral nerve traction test. You would perform this test if your patient is complaining of some numbness, tingling, pain in the femoral nerve distribution area, which is the anterior thigh area. Have the patient inside lying with the unaffected leg lying on the mat and the affected side up. Use one hand to stabilize the hip at the ASIS and use the other arm to cradle the lower portion of the leg and place this hand on the anterior aspect of the knee. Once in this position, you will begin to traction the femoral nerve by bringing the hip into some extension and then gradually bringing the knee into flexion. If bringing the knee into flexion reproduces the patient's complaints, but bringing it back makes it go away, this is then noted as a positive test. The passive lumbar extension test will be the test for when you suspect the patient has lumbar instability, and there is two ways that it can be performed. One way is that the examiner will grab a hold of the patient's legs, lift them up about 1 foot above the trunk, and apply extension. It might be hard to lift the legs high enough and also support the weight long enough to elicit the patient's response, but this is how we have done it in this video. The other way is if you had a segmented treatment table. Position the patient's hips where the break is, and then elevate the lower half of the table, bringing the lower extremities up and placing the lumbar spine into extension. Let the patient stay in this position for about 30 seconds. In this, the reproduced complaint should be a feeling of pain, heaviness, or pressure, not numbness, in the lumbar spine or legs. And if the symptoms resolve once the legs are lowered, this would be a positive test. Another good test to check if the patient has lumbar instability is the prone segmental instability test. For this exam, you need to already have had a general idea at what levels the patient most likely has some instability. Let's say our patient is in the L3, L5 region. The patient will begin in the position, have them bend over, resting on the edge of the table with their arms crossed under the chin and feet flat on the floor. Once the patient is in the proper position, you will begin to palpate using PA glides over the questionable segments. Ask the patient to let you know when their comparable sign is reproduced. You can start at the L5 in our case. Perform a PA glide. The patient says nothing really. Move to L4. Patient reports that does create some pain. We will keep the hand in position at the L4 segment and instruct the patient to hold the edges of the table and lift their legs off the ground, not super high, but ask them to hold in this position. Then repeat your PA glide at the same segment. If the patient reports that it now feels better, the pain is less, this will be a positive test, because the patient has fired their muscles to lift their legs up, and this has helped stabilize the spine. If the PA glide is still just as painful when the legs are lifted, this is a negative test. Body mechanics may have been slightly off due to this table not being adjustable. The H and the I test can be performed when concerned for instability, but also just to assess the quality of motion, how the patient can control their lumbopelvic rhythm. First, we will perform the H test. Visualize you're performing a capital H. Start standing in neutral. Ask the patient to side bend to the right, then flex forward, then stay side bending to the right, and extend backwards. Come back to neutral. Now side bend to the left. Flex forward, stay side bend to the left, and extend backward. As the examiner, you are watching the patient preferably from both the side and the back and looking for any aberrant movement, any shakes. Are they symmetrical when they side bend to the right and left, forward, and back? Now we will have the patient create a capital I. In this case, have the patient first flex and bend straight forward. While bend forward, go to the right, then to the left, opposite. Come back to neutral, standing. Then extend backwards into extension. Go to the right, and then to the left. Looking again for the quality and control of motion, and if pain is reproduced in any portion of the H and I. Positive H and I test for instability is if any aberrant motion, poor quality control, or pain is reproduced in any of these positions. The test for anterior spine instability, or anterior shear, is another instability test for the lumbar spine. This one targets the anterior spine, and you would perform this test if you suspect there's a problem at some lumbar segments. Have the patient begin in side lying. Let's say you suspect an issue at L3, L4. Palpate for the spinous processes, and you will place your fingers over the superior aspect, in our case L3. You will flex the patient's hips to 70 degrees and flex the knees to 90 degrees. The examiner with their hip and stomach will push against their knees in a direct force while stabilizing at that superior segment, ours L3 again. You are pushing on the lower segment L4 posteriorly, which is creating a relative anterior glide of L3 on L4. This is a positive test if you get a clunk, reproduced complaints of pain or heaviness in the legs or spine. This is another test for lumbar instability. Similar to the anterior spine test, just now we'll be testing for posterior spine instability or posterior shear. For this test, we will begin with the patient sitting and instruct the patient to rest their forearms on top of the examiner's shoulders. Again, let's assume we're assessing the L3, L4 region. Find the spinous process of both. We will stabilize with our fingers the inferior segment of L4 in our case. Once we've stabilized the inferior segment, ask the patient to push their arms into you like they are trying to push away. This will then create a posterior glide of the superior segment, L3 for us. This will be considered a positive test if we can reproduce the comparable sign, clunking, or heaviness in the legs. A quadrant test can be performed if you're considering joint dysfunction, specifically at the facet joints. In your exam, you still haven't been able to reproduce the patient's symptoms with simple flexion or extension motions. You can now create these combined motions. We want to again test the side you are less likely thinking would reproduce the patient's complaints than the involved side. Tell the patient, I want you to put your right hand on the back of your right thigh and slide your hand down your leg. This would close off the facets on this side with the extension and slight right rotation. Then can repeat the test on the left. Positive sign for this test would be if you are able to reproduce their complaints of pain when going in these combined motions. The bilateral straight leg raise test, also known as the Milgram's test, is an assessment of abdominal muscle strength as it may cause intrathecal irritability. The patient will be laying supine with both legs fully extended. Then you will instruct the patient to raise both feet about 2 inches off the table and maintain this position for at least 10 seconds and up to 30 seconds. Positive test results if the limbs or affected limb cannot be held for 30 seconds or if symptoms are reproduced in the affected limb. Inability to perform this test due to muscle weakness is not considered positive for this test but should still be noted. Perform this test with caution because of high stress load placed on lumbar spine. A Stork standing lumbar extension test is another test to perform if you are considering joint dysfunction in your patient, specifically signs indicating a pars interarticularis fracture. Instruct the patient to stand on one leg and extend their spine while balancing on a single leg. Perform the side you suspect to be uninvolved first, then the involved. A positive test is indicated by pain in the back and can be associated with a pars fracture. If the stress fracture is unilateral, standing on the ipsilateral leg causes more pain. This test can also be done with the addition of a rotational component. If this combined motion elicits the patient's complaints, it may indicate a possible facet joint pathology on the side the patient rotated to. The Ober test is performed to test the tensor fascia lata or IT band for contracture. This test has also been reported to test glute med and min muscles as well as the hip joint capsule. Therefore, if this test is found to be positive, differential diagnosis should be performed between those structures. The patient will be positioned in the side-lying position with the lower leg flexed at the hip and knee for stability. The examiner will then passively abduct and extend the patient's upper leg with the knee kept straight while maintaining the hip in an extended position. The examiner slowly lowers the upper limb. If a contracture is present, the leg remains abducted and does not fall to the table. A positive test is indicated when the leg remains abducted while the patient's muscles are relaxed. When the test is being done, it is important to extend the hips slightly so that the IT band is passed over the greater trochanter. To achieve this, the examiner will stabilize the pelvis while performing the motions to stop the pelvis from falling backward. It has been reported in literature that flexing the knee eliminates the IT band and the glute med becomes the main muscle being tested because the IT band has greater stretch placed on it while the knee is extended. Additionally, when the knee is flexed during the test, greater stress is placed on the femoral nerve. If any neuro symptoms are elicited during the examiner should consider a pathology affecting the femoral nerve. The Thomas test is used to assess hip flexion contracture. The patient lies supine while the examiner checks for excessive lordosis, usually present with tight hip flexors. The examiner flexes one of the patient's hips, bringing the knee to the chest to flatten out the lumbar spine and stabilize the pelvis. The patient then holds a flexed hip against the chest. If there is no flexion contracture at the hip being tested, the straight leg remains on the examining table. If a contracture is present, as with our patient, the patient's straight leg rises off the table, resulting in a muscle stretch and feel. This would indicate a positive result for hip flexor contracture. The angle of contracture can be measured. If measurements are taken when the test is being done, the examiner must ensure the restriction is in the hip and not the pelvis or lumbar spine. If the leg does not lift off the table but abducts as the other leg is flexed, this is called a J sign or stroke and is indicative of a tight iliotibial band on the extended leg side. A rectus femoris contracture test should be performed when there is a suspected contracture of the rectus femoris muscle. The patient begins standing and then goes into a supine position with the knees bent over the edge of the table as shown. The patient flexes one knee into their chest and holds it. This is not the test knee. The angle of the test knee should remain at 90 when the opposite knee is flexed into the chest. If it does not and the test knee is extending slightly, a rectus femoris contracture is probably present and this would indicate a positive test. The examiner may then attempt to passively flex the knee to see if it can then remain at 90 with its own volition. With any of these contracture tests, the examiner should always palpate for muscle tightness. If there is no palpable tightness, the probable cause of restriction may be tight joint structures, like the capsule, resulting in a different end feel. Both sides should be tested and compared, again beginning with the uninvolved side if there is one suspected. If there is any suspected tightness or shortening of the hamstring muscle, the 90-90 straight leg raise can be performed. Begin the test by having the patient lie in supine. Then take them into the 90-90 position, the hip and knee being bent to 90 degrees of flexion. From this position, we will just passively extend the leg out without losing the 90 degrees of hip flexion. Normal length is that you should be able to get to about 20 degrees of full knee extension. Otherwise, a goniometer should be used to record the amount of extension the patient was able to achieve. This would be considered as tight hamstrings, and this would give a positive result for the 90-90 straight leg raise for the hamstring test. Our patient was able to achieve it, but in the case of being less, it would be positive. Make sure to compare both sides and assess for asymmetry as well. The sign of the buttock test is a special test you can perform if the patient has back or hip complaints. Bring the leg up as you would with a passive straight leg raise. Bring the leg up until it reproduces the patient's comparable sign, hip or posterior hip pain. Then you will bend the patient's knee to take the stress off the hamstrings. Now with the knee bent, see if you can move the patient further into hip flexion. You should be able to because you gave the hamstring some slack. If once the knee is bent you still can't move the hip into further flexion due to pain being the limiting factor, this will be a positive sign of the buttock. This positive sign is typically indicative of a neoplasm or fracture and usually refer the person for medical assessment if positive. There are two tests for suspected instability in the thoracic chain, furthermore to determine if there is a failed or non-optimal load transfer within the thoracic chain. The two tests are the SAL and PAL, sitting arm lift test and prone arm lift test. The way to determine which we'll do is based on the patient's primary complaints. If the patient complains of pain when lifting their arm in early motion up to 90 degrees, the SAL would be the suggested test. If the patient's complaints are past 90, the PAL test would then be more indicated. First, we will demonstrate the SAL test. Have the patient in sitting perform an arm raise overhead on their uninvolved side first. You're assessing what their control is like if they substitute, then have the patient lower that arm and repeat it on the uninvolved side. The uninvolved side would either present as not being as controlled or the patient would complain of some thoracic pain in a general area. At this point, you would have determined some suspected levels, either where the patient indicated pain when raising their arm overhead, either upper, mid, or lower, or through your PA glides. Then you will stabilize those segments and the ribs associated with them bilaterally and have the patient raise their involved arm overhead again while you stabilize each of the suspected segments and their corresponding ribs. If the motion improves in quality or lessens the patient's symptoms or totally alleviates them with the bilateral stabilization, then this is a positive test. For the PAL test, we will want to have our patient in the prone position. This test will be a bit more aggressive because you are now lifting against gravity and stabilizing the lumbar spine a bit more. Have your patient lay their arm out, reaching forward in front of them to get them in a good amount of shoulder flexion, and then take the arm out into some abduction, which is not being shown here due to the table being narrow, and raise their arm up from this position to see if this reproduces the patient's complaints. Then we will repeat as with the SAL test, stabilizing the patient bilaterally at the suspected segments and corresponding vertebra. Have the patient raise the involved arm again, looking for symptoms to be either decreased or relieved or improved quality of motion and control. Either of these two improvements would be considered a positive prone arm lift test. Note to make sure that the hands are being angled properly with the corresponding ribs, either being in the upper or lower thoracic segments. The reflex hammer test is used if a person has history of trauma to the spine or significant osteoporosis and is complaining of thoracic spine pain and you are concerned for a potential fracture. This will be a great test. The patient will be sitting. You can use a reflex hammer or fist to tap over the spinous process you may have encountered tenderness around with palpation or where the patient has been complaining. A positive test would be the patient's pain or comparable sign is recreated when that specific spinous process is contacted with the reflex hammer or your hand. This then makes the examiner suspect a potential fracture or an issue with the bone integrity of that vertebra. If there is a history of trauma, you will probably want to refer them for imaging to help more definitively rule out fracture. Here I am demonstrating the taps over the lumbar spine due to it being more exposed for the video. The Murphy's percussion test is a great test to use to screen for a potential kidney problem. This test should always be correlated with other findings in your exam that make you consider a kidney problem, especially your review of systems. The patient can either be sitting or prone. Prone is probably more comfortable. Place the flat of your hand over the costovertebral angle and thump down with your opposite hand. Compare the involved and uninvolved sides, beginning with the uninvolved. A positive test would be the thump reproducing flank pain on the ipsilateral side.